Let me introduce the first presentation in the Young Physician Forums, the Enigmatic Itch, Exploring its Multifaceted Pathogenesis by Dr. Kasun, Tharaka, Samarakoon, Senior Registrar in General Medicine, National Hospital of Sri Lanka.
Thank you, sir. I also must thank Ceylon College of Physicians for giving me this wonderful opportunity to address in this esteemed forum. So today, the topic that I'm going to discuss is the enigmatic itch, exploring its multifaceted pathogenesis. First of all, I will bring you the objectives of this presentation. First one is urticaria classification. Second, pathophysiology. Third, the diagnostic workup of chronic spontaneous urticaria specifically, and the management of urticaria. So before coming to the term urticaria, I hope most of you have experienced or at least heard of this plant, a flowering plant seen in villages and suburbs that causes intense itching upon contact because it contains chemical substances in the form of formic acid and histamine. So I think you know that is in Sinhala we call it kahambilia, and the Latin term for that is urtica dioica, from which the urticaria term has derived from. So, but we are living in a strange world where stinging nettle is eaten for a world championship that happens annually in the UK. So coming to the topic, the classification of urticaria is divided into acute urticaria if the spontaneous wheal and the angioedema lasts less than 6 weeks, and if it lasts more than 6 weeks, that is classified as chronic urticaria, which is also divided into two: inducible urticaria whenever there is an obvious physical trigger or maybe non-physical trigger, in which case when there is no identifiable trigger, it is labeled as chronic spontaneous urticaria. So acute urticaria versus chronic urticaria. The acute urticaria and chronic urticaria both are more seen in females, but in contrast to acute urticaria, which has a lifetime prevalence of 20%, chronic urticaria has only 1% worldwide prevalence. So what is urticaria actually? So urticaria is intensely pruritic erythematous plaque with or without angioedema in the presence or in the absence of a trigger. So it has three characteristics. One is central swelling of various sizes with surrounding erythema and itchy sensation, and also the fleeting time course that lasts less than 24 hours with the skin in returning back to with the skin returning back to the normal without residual ecchymosis or pigmentation. And a word on angioedema. Angioedema is episodic submucosal or subcutaneous swelling in non-dependent parts, especially periorbital, lips, cheeks, finger toes, and genitalia. And we have to consider acquired angioedema or hereditary angioedema or angiotensin converting enzyme inhibitor induced angioedema. In these two conditions where angioedema occurs without urticaria and episodic abdominal pain due to intestinal mucosal and angioedema. So coming back to the acute urticaria, the pathophysiology. So whatever the type of urticaria, whether it is chronic or acute, is due to mast cell degranulation, releasing the histamines and other leukotrienes. So in acute urticaria, it's mainly immune-mediated type 1 hypersensitive reaction driven by immunoglobulin E antibodies. In addition to immunogenic mechanism, it has also direct effects from some infections, medications, and physical stimuli that can cause acute urticaria. So going back to the immunology basics, the type 1 hypersensitive reaction, as you can remember, is started from the introduction of an allergen taken up by the antigen present in cell, which processes it, and with several processes, it results in immunoglobulin E production by B cells, and then it attaches to the mast cell. And with the subsequent exposure to an allergen, the allergen meets the immunoglobulin E, and the mast cell is stimulated and causes degranulation, releasing the histamines, leukotrienes, prostaglandin, and platelet activation factors, causing vasodilatation, and it results in the urticaria. So the chronic urticaria has a different pathophysiology compared to the acute urticaria. So this has about two main mechanisms. Both are autoimmune, where autoantibodies of immunoglobulin G and immunoglobulin E autoantibodies are formed, and then they cause mast cell activation. So as I mentioned, this diagram shows you the pathophysiology of chronic spontaneous urticaria, where autoantibodies IgE and IgG are formed and they bind the mast cells. Immunoglobulin G can either bind directly to the mast cell via Fc epsilon receptor 1, or it can bind to immunoglobulin E that has already been bound to the Fc epsilon receptor 1. So this chronic spontaneous urticaria, I mentioned it, if we label it, if it lasts more than 6 weeks, it can have various forms. 50% it is driven by urticaria, predominant type, and then in 40% of chronic spontaneous urticaria, it is in combination urticaria and angioedema in combination, and in 10% angioedema predominant. But we have to be careful when a patient presents with angioedema without urticaria, as we have to consider angioedema disorders. So when we come across a patient with long-standing urticaria, we have to also exclude some important medical conditions. So the differential diagnosis that we can entertain are systemic lupus erythematosus. As you know, it usually causes malar rash and discoid lupus lesions and erythematous plaques, but also it can cause urticaria or urticarial vasculitis, and it is related to a severe disease activity of SLE. And second differential diagnosis is urticarial vasculitis, which can occur in isolation or secondary to systemic disease like SLE or Sjogren's disease. And the urticarial vasculitis is usually non-pruritic, but it has a painful characteristic, and it lasts usually more than 48 hours. I mentioned usually the chronic spontaneous urticaria lasts less than 24 hours each episode, the urticaria itself. But in this case, the urticaria lasts more than 48 hours, and the resultant is resolving with residual pigmentation and ecchymosis, which is in contrast to chronic spontaneous urticaria, where the urticaria resolve without any residual mark. And cryoglobulinemia is another differential diagnosis you have to consider. Again, vasculitic lesions are more common in cryoglobulinemia, palpable purpura and livedo reticularis, associated with hepatitis C, especially more than B. And also it can cause cold-induced urticaria. And this is also can be a differential diagnosis. We can entertain Schnitzler syndrome, where it's an adult onset autoinflammatory disorder that is due to a monoclonal gammopathy, along with the other systemic symptoms with hepatosplenomegaly, lymphadenopathy, and it can cause chronic urticaria, but it is usually non-pruritic. So I mentioned earlier, urticarial vasculitis does not cause pruritus generally, and in this case also the monoclonal gammopathy also does not cause pruritus. High ESR and CRP, and it has a dramatic response to anakinra, interleukin 1 inhibitor. So other mast cell disorders So mast cell disorders occur due to excessive mast cell accumulation either in skin or extracutaneous tissue like skin, liver, spleen, bone marrow, and GI tract. So cutaneous mastocytosis is only when the skin is affected and when other organs are also involved in addition to skin, we label it as systemic mastocytosis. So in cutaneous mastocytosis, multiple monomorphic reddish lesions appear in the beginning, which progress to brown macules, which may become confluent later on. So the Darius sign you have to be aware of, that is a pathognomic phenomenon of urticaria pigmentosa, that is cutaneous mastocytosis. So this is what I mentioned about cutaneous mastocytosis. The presentation is like this. Initially reddish maculopapular lesions become confluent subsequently with time. So Darius sign, so that is we have to scratch a newly formed lesion when the patient is not on antihistamines. A gentle scratching causes urticaria to develop because of the mast cell releasing of the histamine. So that is development of an urticaria after gentle scratching within 2 to 5 minutes is positive Darius sign that occurs in cutaneous mastocytosis. So systemic mastocytosis, as I mentioned earlier, has other organs involved which can cause anaphylaxis, especially following insect stings and hepatosplenomegaly, and also it can cause osteoporosis resulting in bone fractures. So hypereosinophilic syndrome is also another differential diagnosis to consider. So the prognosis is actually mainly it causes a very poor quality of life, affecting the attention, the confidence, and relationships of the patient. And the cause of the disease, usually it's self-limited disease, which can last up to 5 years, but unfortunately in 30% of cases, it can persist beyond 5 years. So we also have to consider the associations of chronic spontaneous urticaria. Usually the atopic conditions are not associated with chronic spontaneous urticaria in adults, but can be associated in children. Mainly the autoimmune conditions like celiac disease, autoimmune thyroid disease, Sjogren's disease, SLE, type 1 diabetes mellitus can be associated with chronic spontaneous urticaria. More importantly, thyroid and chronic spontaneous urticaria, they have a close relationship because compared to the general population, patients with chronic spontaneous urticaria have higher prevalence of hypothyroidism and also hyperthyroidism. And they can have higher prevalence of positive antithyroid peroxidase antibody. What it reflects is poorly responding chronic spontaneous urticaria if anti-TPO antibodies are positive. So the standard therapies that I will be discussing in the subsequent slides. So how to diagnose chronic spontaneous urticaria? Usually it is a clinical diagnosis. So clinically, the history, examination, and investigations with or without skin biopsy, we can diagnose chronic spontaneous urticaria. So a simple algorithm to ease the diagnosis wheels, first we have to see whether this patient has unexplained systemic symptoms, in which case it can be autoinflammatory disease. In the absence of systemic disease, then we have to see whether this patient's wheals last more than 24 hours, which can be due to urticarial vasculitis, in which case we have to arrange skin biopsy to confirm urticarial vasculitis. And if the wheals last less than 24 hours, then we have to see whether there is a provocation or any inducible trigger, in which case it can be chronic inducible urticaria. In the absence of any trigger, we can label it as chronic spontaneous urticaria. Then if the patient presents with angioedema, first thing we have to see whether the patient is on ACE inhibitors, and if patient is already on ACE inhibitors, we have to see whether patient responds after stopping ACE inhibitors. And if not on ACE inhibitors, then we have to consider acquired angioedema or hereditary angioedema depending on the history. So talking about the initial investigations, basic full blood count can be helpful because basopenia may reflect a severe disease which may be less responsive to the standard treatment. And eosinophilia does not occur with chronic spontaneous urticaria, so it can be due to parasitic disease or atopy. So CRP and ESR, the inflammatory markers may be high in the presence of vasculitis or maybe systemic disease, as I mentioned earlier, or maybe monoclonal gammopathy. And thyroid stimulating hormone and anti-TPO antibodies are also important for the reasons mentioned before. And also on some occasions, lymphoma and some hematological malignancies also can be associated, but they are not routinely done. We have to do them individual basis. So additional testing is done only if warranted. So if the patient has high ESR or CRP, then we have to exclude other systemic diseases, and then more specific tests where we can do autologous serum skin test where we inject histamine and see whether this patient develops the urticaria, in which case that indicates presence of autoantibodies. And skin biopsy has to be performed if vasculitis is suspected. So moving to the management of chronic spontaneous urticaria, the first thing is trigger avoidance. Especially more importantly, NSAID sensitivity may be variable, but we can try stopping NSAIDs if the patient was on. First line treatment is second generation antihistamines like cetirizine, loratadine, fexofenadine, because it has an enhanced safety profile as well as reduced sedative effect compared to the first generation antihistamines like promethazine, chlorpheniramine. And also, more importantly, it can be used as an add-on with second line omalizumab and third line cyclosporine A. So this is the mechanism of second generation antihistamines, which is little different from what we have been thinking of. It has the inverse agonism, not just blocking of histamine 1 receptor, because so this histamine 1 blockers, receptor blockers, the second generation antihistamines, they cause inverse agonism. So that means the histamine receptor is stopped in its inactivated state. So the histamine molecules cannot bind histamine receptors. So it is this simplified diagram shows the histamine receptor blockers maintain histamine receptor in inactive state, not allowing histamine to bind. So this is the mechanism that I described just now. So second generation antihistamines, they have fairly a quick action. Onset of action is less than 4 hours and it can last for about 24 hours. So sedating effect is not proportionate to the potency of antihistamine. So this is a question to the audience. So can think that patient has been on antihistamine, second generation antihistamine for about 2 to 4 weeks with poor response to the initial standard dose. So the standard dose is for loratadine, it is 10 milligrams per day. Cetirizine, it is 10 milligrams per day. Fexofenadine, it is 180 milligrams per day. So out of which would you recommend to do next in case of a poor response to standard dose of second generation antihistamine, whether to double the dose, whether to triple the dose, whether to quadruple the dose of standard dose, or add another second generation antihistamine like loratadine added to cetirizine like, then or else add first generation antihistamine or combine with famotidine, ranitidine like antihistamine to receptor blocker. So the answer is, so when we talk about the stepwise treatment, the standard dose is continued for about 2 to 4 weeks to check the response. If the response is poor, then of course you can increase the dose by up to 4-fold. So for example, if the patient is on fexofenadine, you can give the maximum dose of 360 milligrams twice a day or loratadine 20 milligrams twice a day and continue at the same high dose for about 4 weeks and see the response. So if there is no improvement, there is no benefit in adding another second generation antihistamine or adding anti-H2 receptor blocker. So straight away you have to start the second line, that is omalizumab. So response to treatment can be assessed with the urticaria activity score 7, urticaria control therapy, and cruise app. So these are patient-driven disease activity scores. So this is cruise control that is available on devices, mobile phones. So the general approach is to maintain the remission for 3 to 6 months before deciding on gradual reduction of doses. Omalizumab, the second line, which has it is a monoclonal antibody against immunoglobulin E antibody, and cyclosporin A, the third line medication, if the patient does not respond to omalizumab. So that is inhibiting T cell activation and proliferation, resulting in autoantibody production inhibition by B cells. So that is shown in this diagram. So cyclosporin A treatment duration can vary from person to person depending on the response to the treatment. So from 4 weeks to 10 years, there have been trials that the patient had been on cyclosporin A treatment. So once the patient is on cyclosporin with good response continuously for more than 3 months, then the dose can be tapered. So this is the summary of the treatment. First line, second generation antihistamine, then omalizumab, the second line, then third line, the cyclosporins. So depending on the response, you can taper the doses. So there are other emerging treatments like dupilumab and other monoclonal antibodies. They are under investigation for the treatment of chronic spontaneous urticaria. So I will be discussing about the acute urticaria because there are no studies done for acute urticaria because it is self-limiting and it is short-lasting. So there is some controversy in the process of management of acute urticaria. Still, the first line is avoidance of the trigger and second generation antihistamine. So second generation antihistamine should be continued for about 2 to 3 days after the urticaria settles and no more new lesions form to avoid the rebound symptoms. And as the chronic spontaneous urticaria didn't have any place for glucocorticoids, acute urticaria, the glucocorticoids may be used very rarely if there is poor response to second generation antihistamines, and also it is prescribed for a very short period of about 5 to 7 days. So to wrap up my presentation, the key messages I can present here are: the urticaria is not always allergy. Treatment is never multiple antihistamines in combination with or without prolonged period of glucocorticoids. So there is no place for glucocorticoids in chronic spontaneous urticaria. Timely stepping up of treatment should be instituted to reduce the patient's well-being. Thank you very much for the audience, and these are my references. Thank you.
Okay. So the presentation is now open for discussion. Any questions?
You see that sometimes they do this skin test, various antigens on patient with chronic urticaria. Is it of any value?
Yes, of course. For acute urticaria, you can perform a skin prick test when we suspect that is allergic, when the urticaria occurs after a trigger, but unidentified trigger that develops within first 48 hours. But if the type 4 hypersensitivity reaction that occurs as in contact dermatitis, and so in that case, we can perform the skin patch test. So the difference between the two is the skin prick test once the allergen. So those are performed on allergens like pollen, then animal dander. So those allergens are used in the skin prick test, where once the skin is pricked with the allergen, the reaction occurs within 20 minutes. In contrast to skin patch test, where nickel and then rubber, latex, those are tested by a skin patch test, where the results, the reaction occurs after 48 hours. So there is a place for those two, usually in acute urticaria, not in chronic spontaneous.
Yeah.
Yeah.
A lot of people ask, when patients come to gated area, should you avoid certain types of, like, common food that they get allergy to, like prawns, cuttlefish, that type of thing they ask, whether to avoid those.
Yeah, of course, in acute urticaria, there is a significant place for avoidance of an identified trigger in the form of food or food additive. But when it comes to chronic spontaneous urticaria, it has been found that it's not actually mostly not due to the additives in the foods. It is actually the fluctuations of the spices causes fluctuations of the spices cause this chronic spontaneous urticaria, not even additives. But in the case of acute urticaria, of course, there is a significant place in the management by avoiding the triggers identified